Post-traumatic stress disorder is a mental disorder diagnosed after an exposure to trauma, including actual or threatened death, serious injury, or sexual violence. It is characterized by intrusive and distressing memories or dreams, dissociative reaction, and substantial psychological or physiological distress related to the event. A diagnosis of PTSD requires evidence of exposure to trauma and is characterized by intrusive and dissociative symptoms. Mentions of combat stress or shell shock can be found over 2,000 years ago in historical literature to the days of Herodotus in 5th century ancient Greece. Based on many sources, you could say that the history of PTSD dates back to 2,000 years ago. Even Shakespeare alluded to what could be PTSD in various plays. By the 19th century, mentions of PTSD were characterized as battle exhaustion or soldier fatigue. References to repeated exposure to battle by soldiers, the disorder was thought to be related to exhaustion. It was often referred to as the 1,000-yard stare, as referenced to a blank look and dissociative demeanor of traumatized soldiers. In 1887, Jean-Martin Charcot wrote that traumatic experiences could lead to hysterical attacks that could occur years after a person experienced the trauma. The National Museum of Civil War Medicine is still uncovering information about PTSD related to the U.S. Civil War. PTSD wasn't only the result of combat. Difficult living situations also gave way to trauma and PTSD symptoms. Railway Spine described psychological responses in those who witnessed or endured graphic railroad accidents in the late 19th and early 20th century. In 1915, the term shell shock was introduced with the same symptoms as PTSD and went on to become the predecessor of the official diagnosis. At this time, treatments ranged from psychoanalysis to electric shocks. By the 1950s, treatments for shell shock became more humane, but the stigma of mental illness remained. In the 1970s, PTSD gained the spotlight as countless Vietnam veterans began experiencing psychological problems. This led scholars like van der Kolk, now a leading expert in PTSD, to truly begin studying and attempting to treat PTSD. In 1980, the term post-traumatic stress disorder was added to the Diagnostic and Statistical Manual of Mental Disorders. PTSD is unique among the psychiatric diagnosis in that it requires a specific external event as part of the diagnostic criteria. Incorrect application of the trauma exposure criterion by clinicians and researchers has led to misdiagnosis and high prevalence rates of PTSD. It is important to recognize that for the majority of individuals, exposure to trauma does not result in PTSD. The symptoms from PTSD must be linked to a traumatic exposure to qualify as a PTS symptom. PTSD is marked by intrusive thoughts, avoidance, negative mood and thoughts, and hyperarousal.
So your fight and flight system is a system that is primarily used for when your body perceives it's in danger. It's in a resting state. It switches on, pours out adrenaline and noradrenaline and epinephrine and these kind of things to help you either run or stay and fight and protect yourself. In people who develop anxiety disorders, and PTSD is really at the top of that spectrum of sympathetically driven anxiety disorders. The other ones include generalized anxiety disorder, panic disorder, sometimes social anxiety disorder, obsessive compulsive disorder. They kind of all segue up, and then PTSD is kind of the worst manifestation of that. So genetically, some people have a predisposition for that system. Instead of switching on in the appropriate time when there's danger and then resetting to normal, the system kind of, I always describe to patients as becoming locked. And so it gets stuck in a hyper-aroused state, and that manifests then with all of the criteria that you typically see with PTSD, which cover, again, it's actually 8 criteria, and it can encompass things like nightmares, disturbed sleep, anger and irritability, chronic pain such as headaches and chronic neck pain. It can manifest in other areas as well, constant ruminations, low self-esteem, poor difficulty concentrating. There's actually a lot of criteria that's with it. And it's very, very prevalent in the community. People always think PTSD is just something that applies to the military. And the military kind of used, it used to be in World War I, it was shell shock. Yeah. And then they segued, because PTSD kind of sounds better, but it's still a very dramatically debilitating and serious condition that results, especially in the military, in a lot of suicides every year, and especially in this area. But it's actually far more prevalent in the population at large. There's probably about 22 million Americans right now with PTSD, mostly from severe childhood, physical, sexual abuse.
Childhood trauma has lasting effects. A study conducted by the CDC and Kaiser Permanente concluded the higher the adverse childhood experience survey scored, the greater risk for heart, lung, and liver disease, obesity, diabetes, depression, and substance abuse. The paper, The Biological Effects of Childhood Trauma, concludes that trauma in childhood has serious consequences for its victims and for society, and despite the widespread prevalence of childhood trauma, less is known about trauma's biological effects in children as compared to adults with trauma history, and even less is known these pediatric mechanisms underlie trauma's short-term and long-term medical and mental health consequences. Childhood traumas, particularly those that are interpersonal, intentional, and chronic, are associated with greater rates of PTSD, PTSS, depression, and anxiety, and greater risk for alcohol and substance abuse disorder. PTSD is synonymous with veterans. However, statistics show that there are larger numbers of those who struggle with PTSD outside of that demographic. An estimated 8% or 22 million Americans have PTSD. According to Veterans Affairs, women are more likely to develop PTSD than men. About 8 of every 100 women, or 8%, and 4 out of every 10 men, or 4%, will have PTSD at some point in their life. This is in part due to the types of traumatic events that women are more likely to experience, such as sexual assaults, compared to men. The ICD states that females with complex post-traumatic stress disorder are more likely to exhibit a greater level of psychological distress and functional impairment in comparison to men. Individuals with PTSD are 80% more likely than those without PTSD to meet criteria for another mental disorder, including depressive disorders, anxiety disorders, substance use disorders, in particular alcohol use disorder, and borderline personality disorder. First-line treatments for PTSD include psychotherapy and pharmacotherapy, or their combination. The overall success of current PTSD treatments is low, with rates of remission generally ranging from 30 to 40%. According to surveys of veterans with PTSD, barriers to seeking and accessing treatment include concerns about treatment, emotional readiness for treatment, stigma, and logistical difficulties. Contributors to poor compliance with common psychological and pharmacological treatments may include the many weeks to months required, potential side effects, and comorbidities. Due to these limitations, there is a great need for innovative approaches to further improving the health and well-being of people with PTSD.
People present for a multitude of reasons. It's typically when their symptoms are impacting their daily life to the extent that they don't feel functional anymore. There's a whole host of treatment options. Somatic treatment, when you look at the work by van der Kolk and the Body Keeps Score, we hold memory in our body from the time we're in utero to where we are now in life. And it's important. A lot of people with anxiety and trauma have shut down their body, and it's no longer connected. So it often involves some somatic work, getting them back into their body, getting them grounded and centered. Also, there's cognitive behavioral, which is working from our thoughts to our reactions and responses to things and the emotional outcome. Oftentimes people present with, logically they understand. For example, logically people will say, I know I'm doing well. I know I'm successful at work, or I know I'm successful in this area of my life, and I don't feel like I'm worthy, or I don't feel like I'm enough. So their logic and their emotions are not in the same space, which moves us into also incorporating dialectical behavioral therapy, which is working in our logical mind and our emotional mind to bring them together to our wisest mind, which is both of them working together. That honestly incorporated with EMDR, which is eye movement desensitization and reprocessing, is extremely beneficial. It's a very well researched and evidence-based practice. It replicates or mimics our REM sleep, and a therapist facilitates the replication of REM sleep that people will process. We'll start with the emotion, the negative belief, or the event.
Examples of psychotherapy modalities used for PTSD include exposure-based therapies, cognitive-based therapies, stress inoculation test training, and eye movement desensitization and reprocessing. The psychotherapies include 5 components: narration, cognitive restructuring, in vivo exposure, stress inoculation skills, and psychoeducation. EMDR has shown to be effective and cost-efficient in clinical trials. One study tracked fear extinction after EMDR through fMRI. There were functional changes involving the fear circuit. These modifications created significant improvements for patients. Both EMDR and CTPSD were associated with significant reduction in PTSD symptoms. Probable complex PTSD was associated with higher levels of symptoms before and after treatment, but did not significantly impact the effectiveness of the treatment. An evidence-based approach to psychopharmacology for post-traumatic stress disorder was updated in 2022 to take into account new medications and changes. Treatment for sleep remained the first recommended step, with variations for nightmares and insomnia. If significant non-sleep PTSD symptoms remain, an SSRI should be tried, followed by a second SSRI. If unsuccessful, treatment may expand to mood stabilizers, anticonvulsants, antipsychotics, and other agents. In the study, gender differences in medication prescribing patterns, women veterans with post-traumatic stress disorder have historically received more psychiatric medications than men. Relative to men, women are slightly more likely to receive antidepressants recommended for PTSD in 2019. However, gender differences for medication recommended against use for PTSD were notably larger, including benzodiazepines and antidepressants recommended against use for PTSD. More than 50% of individuals who enter treatment for post-traumatic stress disorder are prescribed a psychotropic medication. To date, however, data are limited regarding the prevalence and determinants of discontinuation of psychotropic medications in this population. Results revealed that 71.8% of veterans discontinued medication treatment within 180 days, and 34.6% within 30 days. The strongest risk factors associated with discontinuing medication were no engagement in adjunctive psychotherapy and prescription for a single medication. Stellate ganglion block, SGB, also called cervical sympathetic block, has been promoted as an alternative for individuals with PTSD who have not fully responded to conventional therapies. SGB might inhibit connections between the peripheral sympathetic nerve system and regions of the cerebral cortex thought to be abnormally activated in PTSD. Studies that have examined brain imaging before and after PTSD treatments provide potential evidence of this biological rationale for the effect of SGB and on PTSD. SGB may destigmatize treatment by offering a biological approach to PTSD management. It may offer a fast-acting treatment alternative with improvements reported within minutes to days of the procedure, and it may increase compliance as it does not require continuous daily or weekly administration. In uncontrolled, unblinded, retrospective case series, SGB for PTSD had high rates of rapid clinical improvement in PTSD symptoms, 70 to 75%. However, findings from the first randomized trial, RCT, of SGB for PTSD were inconclusive, neither confirming or refuting findings from case series.
So your stellate ganglion block is otherwise known as your cervical sympathetic plexus, and it's a driver of your fight and flight system. That's how people understand it more commonly. If you look in the literature, the typical patients are like my 2 lovely patients here, veterans. They're a little easier to treat most of the time because it's an adult onset type of PTSD. It only really manifested as people got older and with trauma as adults. And so oftentimes it's fairly easy to reset those patients with just a few blocks. But I can typically get most people reset with the initial series to benefit more from counseling, which is why I always recommend my PTSD patients stay with their counselors, stay on their medications until their series is over, because there's often a lot of stuff that still has to be worked through, and they actually benefit more because sometimes when patients are getting counseling or even medications, the problem is still so bad. The physiological problem of PTSD, physiological, anatomical, so that's what differentiates it from depression, which is often a chemical imbalance, right? So I'm fixing an anatomical, physiological problem. There's no medicines or counseling that can fix it. So until you've fixed it, patients don't really get the full benefit of the other treatments. But typically, once my patients are reset and the main PTSD criteria are resolved, a lot of them, about 50-60%, are either able to stop medications entirely or at least significantly reduce the medications they're on, which most patients are usually pretty grateful for. I use ultrasound guidance only for my injection. This is an injection in an area that has a lot of important structures, and ultrasound really is the gold standard. The injection itself, from start to finish, probably only takes about 2-3 minutes. There's the only part that is slightly uncomfortable is where I numb the skin and this muscle, sternocleidomastoid. There's a slight, burning like you get with local anesthetic for maybe 3 or 4 seconds. The risk of an adverse effect, like going into a blood vessel or something, is almost zero because I can see everything. So the main injection part takes under a minute, and that is not painful. I mean, you can tell if you get a perfect block each time because you get something called a Horner's syndrome where the eye droops and actually the pupil gets smaller and you feel kind of a warmth on the side of your face, decreased sweating. So there's kind of a built-in mechanism of saying, hey, did the doctor do it correctly or not? Most insurances are saying it's experimental, even though there's intense data in the medical literature. And actually, Sean Mulvaney and Eugene Lipoff, who are the big guys in the military, they've treated a lot of military PTSD. They've presented at numerous conferences that there's more than adequate data because they've known about stellate blocks working for PTSD since the 1990s. But typically we do this block for headache syndrome, CRPS, atypical facial pain. In terms of what I've done and the vast diversity of the types of PTSD, and as I say, not just PTSD, OCD, all of those things that I've treated, there's really not even a lot in the medical literature. I did win the White Paper Award at the American Society of Pain and Neuroscience 2 years ago, and I'm hoping to publish fairly soon. Fascinating to watch, and it's a wonderful thing to watch. When I first started doing this, because I'd observed some of the data that was presented at a conference, I said to myself, this is too good to be true. And it's been the most fulfilling thing I've ever done as a physician.